This is the Dissemination Research and Implementation Science Seminar, DRISS, that we had last year, and we are continuing into this academic year. This year, DRISS is presenting translational education for advancing community health, which is, we've said, is TEACH, recruitment science. So it's really exciting to think about this connection or overlay between implementation science and recruitment science, and thinking about where that bridge occurs and how this both of these sciences can really help us advance our research and recruitment efforts. So I'll introduce myself. I'm Barb King. I'm a professor in the UW School of Nursing. As you know, as similar to last year, TEACH-RS will be a monthly lunchtime seminar, and it really gives us this wonderful opportunity from our amazing researchers across campus on some of the research we're doing and strategies we're using to improve recruitment. This seminar will take place on the second Friday of every month from noon to 1 Central Time. For the entire academic year, our last seminar will be in May. It's open to everyone, so tell your friends, family members, and colleagues about this wonderful learning opportunity that we have. Also, for those who are interested in or registered in the Implementation Science and Community Health Outcome Certificate that we offer through ICTR, this seminar series also fills the requirement for the seminar option for the certificate. So now let's get on to Christie. So Dr. Christie Bartels is a physician and Chief of Rheumatology at the University of Wisconsin, and she is the chair of the American College of Rheumatology, identified as ACR, Registry and Health IT Committee. As a rheumatologist and implementation scientist, Dr. Bartels' work aims to reduce cardiovascular disease and disparities in lupus and rheumatic diseases. Her research has led to over 100 peer-reviewed publications, and she is cited in the U.S. cholesterol guidelines. Dr. Bartels co-led the American College of Rheumatology CDC project, authoring the first lupus quality guidelines. Her research has been funded by the National Institutes of Health, Department of Defense, Rheumatology Research Foundation, the Wisconsin Partnership Program, and many others. She serves on 2 editorial boards and received the Arthritis Foundation Community Impact Award, mentoring awards, and has repeatedly been listed as one of the top doctors in America. So we are thrilled to have Dr. Bartels kick us off in this seminar series. So I'm going to turn this over to her and allow her to present. If you have a question or comment, please use the raise hand feature that of Zoom, and wait to unmute until our presenter calls on you. You can also use the chat function in Zoom, and we'll monitor that as well. So I'm going to mute, and Dr. Bartels, I will let you take it from here.
Thanks so much for the kind introduction, Barb. I appreciate it. And thanks for coordinating to all the entire D&I team here for coordinating the seminar as well. Really grateful to be here with this team. And some of you have heard our work before. We're going to try to put a little bit of a different spin today. When we think a little bit about recruitment science, Dr. King has already pointed out that recruitment of participants is certainly one way to think about that. The other piece is thinking about recruiting sites, recruiting teams to help you within those sites. And so you're going to hear some themes about that. But the overarching umbrella today is really framing some of our work that we've done in the realm of pragmatic studies. So we'll start off in the nuts and bolts of pragmatic studies, talk through a few examples from our experiences, and then share some lessons learned. I often think that when we tell people what went well, but also tell people what was a challenge, I often learn more when people are willing to share their challenges. So we'll let you kind of see behind the curtain some of the things that were struggles and lessons that we learned along the way too. So thank you guys for the opportunity today. I also want to just put in a quick plug at the top of the hour, and I'll try to remember to do it again at the end of the hour as well, is that October 21st and 22nd is the D&I short course. It's free, absolutely. And I'd really encourage everybody on this call, register to come, even if you can't come for every single minute of the full 2 days, register, come. It'll be a great session with 2 fantastic speakers. And again, great to build this community. So thank you all for attending the DRISS seminar, but also encourage you to come to short course. And with that, I will launch into some slides here. So we'll do a quick screen share and get kicked off. So as I'm loading these slides, one thing I always just share with people is that as a rheumatologist, people are sometimes surprised that I care so much about cardiovascular disease prevention. And part of the issue here is just that the patients I take care of get heart disease 10 to 20 years before peers. So for instance, the average 45-year-old woman with lupus has 50-fold higher risk of heart disease than her peers without lupus. So it makes it a big deal. And so it really has been something that has been a mantra for me to figure out how can we get specialty clinics on board with helping to do that prevention piece that normally would happen in primary care, recognizing that patients who have diseases like RA or lupus are going to see specialty care more often than primary care. So how can we partner? And some of you have heard me present before, and like I said, we'll do you'll hear some familiar themes, but you'll also hear some new pieces of data as far as how we got people on board with that message and how we implemented a couple of interventions called BPN Quick Connect, not only in rheumatology, but in other specialty clinics as well. And we'll talk more about that. So a couple of objectives today. First is that we'll talk a little bit about the rationale for pragmatic studies. Then we'll talk a little bit about how to do adjusted and unadjusted analyses when you're looking at pragmatic studies. We'll talk about using EHR data, specifically in multi-center studies, which requires sort of some additional skills and gymnastics, I would say, to get that pulled off. And then we'll share some lessons learned as we engage staff and teams and patients across these sites. And I've just got a listing here of some of the sites that we've had the good fortune of being able to implement with over the years. So the first piece is just to kind of level set with this idea of pragmatic studies. So pragmatic studies are types of clinical trials that evaluate effectiveness in real-world clinical settings. And when we think about this, this is really in contrast to thinking about the typical RCT or explanatory trials, where we're really thinking about the efficacy of a treatment in an ideal condition or an ideal setting. So sometimes, these are kind of real world. There are pluses and minuses of all of these approaches. But when we think about it with the pragmatic studies on the left, it's one of the pluses is that we get pretty representative participants because often we have really broad inclusion criteria. We can think about delivery of this in a standard setting. We can focus on outcomes that really are deemed important in the long run, and we can follow it using standard clinical data. So those are kind of some of the advantages of why you might choose a pragmatic clinical trial versus traditional trials where, again, obviously highest level of evidence. So not to begrudge this at all. This is highest level of evidence if you're able to do this, but for some things it makes more sense than others. But again, in traditional clinical trials, you can be really highly selective about who's in or who's out. You can deliver the intervention in a really controlled environment. They often focus on a more focused, singular outcome. And then again, they get close follow-up, which again, some of you know too, that sometimes that ends up being part of the intervention as well as these frequent points of contact. And so again, there's trade-offs when one is considering both of these models. And this was just a slide from the British Columbia, a Canadian website, kind of highlighting these two. The more nuts and bolts granular look at pragmatic versus classic RCTs, I really like this schematic that came from actually some rheumatologists who are doing osteoporosis studies that are pragmatic studies out of University of Alabama. And they really point out that, again, the purpose, again, is effectiveness versus efficacy. Selection is broad versus selective in RCTs, and exclusion criteria are really few. And you'll hear this in a bit that we sort of said anybody who came to our clinic who had high blood pressure was in for BP Connect, for instance. Burden is usually minimal. Often we can get waiver of informed consent because often these are things that should be happening in routine care anyway. And so that can be helpful. And then randomization, and you'll hear this later too, that when we did some randomization in a couple of our more recent studies, we randomized at the clinic level, not the patient level. So again, a little different perspective there. Outcomes, you'll hear a little bit about how we used EHR outcomes for that. We have the advantage then that we can do long-term data linkage. And again, procedures are usually fairly straightforward and not necessarily complex. RCTs, on the other hand, again, you kind of could see the contrast all the way down, but specifically in an RCT, if you're going to use a multifaceted, complex research intervention that requires delivery by a study team, again, that's the way to go, is to do the classical trial. So again, definitely roles for both types of studies, but just wanted to kind of take a minute to just step back and think through kind of the pros and cons of those different approaches. So many of you know that I was really inspired when I saw the JAMA trial publication of the Kaiser Permanente blood pressure control protocol study. So basically, Kaiser Permanente, fabulous place where lots of pragmatic studies happen. Single EHR, so they can, and then single health entity, so they can implement interventions across many sites. They can monitor them all in their same EHR. And what they did is they deputized their nurses and pharmacists to help with hypertension control. And what they were able to demonstrate was that at a population level, they were able to exceed their own prior baseline, as well as the California and national norms for blood pressure control percent, getting from a baseline of around 60% up to the Kaiser Permanente of around 80% by 2009. And that was across a huge population of 652,000 patients. So again, to enroll and consent 652,000 patients, really not feasible, but really also kind of, this is an example of where they were able to just do this in a real world setting and then watch data over time. And this was pretty inspiring to us. And we just asked the question of, could you use similar protocols like this in rheumatology care to get people at least to follow up for their hypertension? I partnered on the right here with Dr. Edmund Ramley, who is now at Indiana University, who is a health systems engineer. And we basically adapted from that Kaiser model what we called the BP Connect intervention, saying that people came into our clinics and had high blood pressures. We were going to check and remeasure, confirming that they really were high. We're going to advise, tell them why it mattered in their rheumatic disease. We were going to connect them back to primary care if they were high. Our research question was whether we could improve timely primary care follow-up. And we had a second question of maybe whether at the population level we would change blood pressure trends. And again, eligibility for us was really pretty simple. We said any adult in our clinic with high blood pressure was in. So we weren't really disease specific, and we were pretty inclusive. So we wanted to look at those process measures no matter why people were in the clinic. For the outcomes, we wanted to look at timely follow-up. And again, only people who have primary care in our network are we going to have conclusive evidence for when they had primary care follow-up. You'll hear it in a minute. We got creative later and got even more data, but we had about 64% of our patients had primary care in our system, and then we could get that, ascertain that outcome. So for the primary outcome, we had to subset the data just a bit, but again, looked at it over a really broad population. Many of you guys know, again, everybody on this call knows that you can't just build an intervention and expect people to do it. You have to support it with implementation. And again, some of you have heard this before too, that we did this detailed co-design with the clinic team. So every clinic that we were going into, we sat down, did a focus group, worked with MAs, nurses, schedulers to just tailor or co-design the intervention. We educated them why it mattered. We set up these nice EHR reminders, and then we did monthly audit feedback. And in this original study, we did monthly audit feedback one-on-one, which we found was really labor intense. And later on, we tested some other modes of audit feedback that we'll talk a little bit about here too. The bottom is just a publication on what we learned about audit feedback from this process. In the background of all of this, as we were building, we were actually creating a build guide because we knew we didn't want to do this just at one study or at one site. And what you can see in the upper right here, this is Dr. Danny Panyard. Danny is now a postdoc at Stanford, but when Danny was with me as a master's student, actually, he had recently worked at Epic. So the beautiful thing was, as we were building this, we were able to create a build guide to help other people translate and replicate what we had done. So this is published at the connecthealth.wis.edu, also linkable from the HIP Exchange website. But he was able to create these sort of EMR agnostic instructions and almost a cookbook for how to recreate this with 2 alerts. The first to say remeasure, the second to say if you're remeasured and you're still high, to go ahead and offer follow-up. And then working with our engineer friend, Dr. Ramley, and all of our key informant medical assistants, we also were able to nest all this really nice, these blue points here, which are talking points that MA said, you know what? Sometimes I just don't know what to say. So we literally put the script in with the order set. And so this was a new design feature. So 1, we built this, and 2, we created the build guide so that other people could build this as well. The other thing we did sort of under the hood and behind the scenes was that here, for instance, if they made an offer to get a patient connected back to primary care, we actually tagged this order so that it would say offered and accepted, offered and declined, so that the staff would get credit for making the offer. So we made this thing called a smart data element, and it actually then, when you clicked that, one is it blew the order out to the scheduler to schedule the follow-up, but two is it actually gave credit to that individual MA so that when we did audit feedback, we knew whether they had actually A, remeasured if it was high, and B, if they had at least offered, right? They can't necessarily control whether the patient says yes, but they certainly could control their behavioral part of at least making an offer. And so this again was all part of the build guide on how to tag that so that we could do some monitoring and reporting there. So we ended up with two different data sets. And again, pragmatic studies, you're always kind of putting on your hat of like, how can we grab data through kind of usual care processes? So blood pressures were already getting recorded. It was easy to just grab off a vital sign table to see who got more than one blood pressure at a visit if it was high. But then, like I said, we built these smart data elements so that the connection offer, if they offered and patients accepted or declined, or if they already had scheduled follow-up, again, had a button for that so that so that the staff could get credit for those process steps. And monthly we ran reports and we ran them across the clinics, and we sometimes sliced the data at the clinic level, sometimes sliced it at the individual level, and then gave them feedback to let them know how they were doing. And the cool thing there too is we could say, because of you, 20 patients came back and got follow-up last month, or, you beat your last month's goal, right? We could get them motivated to do that. And then ultimately we could also see the running toll of how many patients had come back to get follow-up. And again, that was kind of motivating for the group too, to see, boy, they were really making a difference. So that was cool. So again, this was monthly level audit feedback that we were getting using EMR data, using some research reports. And I'll show you in a second what those reports looked like on our end. But the other thing we were doing while we were doing the intervention was creating a patient visit level limited data set. So again, worked with folks in the Health Innovation Program. We more recently are switching over to the Chi2 group with Jamal Matthews' group to help do this in an operations setting. But essentially, we also knew we wanted to do some controlled analyses that had adjustments for things like patient sociodemographics. We knew that women come to clinic more than men. We knew that people with insurance might come to clinic more than, or certain types of insurance and low copays might come to insurance more. We knew that other comorbidities might impact whether you, again, came and followed up for blood pressure, if you'd already had a heart attack, for instance. And then we also knew that, your past visits predict your future visits. So if you were a high utilizer at baseline, that probably would impact the likelihood of coming back. So again, we were able to collect all those things using EMR data. So once post the visit, we were able to define 2 periods, pre and post, and we were able to do a controlled analysis to look at the impact of the intervention, controlling for a number of different factors here. So we had a publication in 2019, and we were incredibly pleased to show that at 6 months, again, we had a 2-fold odds ratio, even after full adjustment, that the Quick Connect intervention doubled your likelihood of getting a timely follow-up in primary care, which was our intended outcome. And in fact, sustainment at 18 months showed that we did even better. We were at 2.16 for an odds ratio. So again, looked even better over time. And I can proudly report that this is, actually still in action. We're trying to do some additional reboot now that post-pandemic, but essentially pieces of this are still in action 7 years later, which is really awesome. The other piece here is that we were able to then look at subsets, and we found out that for Black race, patients did even better. So basically, patients of Black race had an additional gain over their baseline. So again, this was also nice to see too. So we saw that overall protocol-based care, A, improved outcomes, and B, improved outcomes and reduced disparities. So that was really nice to see. And then later, when we looked at follow-up, we saw that they improved blood pressure control at a population level. And this allowed us to basically bring this to other systems and say, look, we've got data across 56,000 encounters, which again, a pretty big N here because of the pragmatic approach that shows that we were able to get a systematic reduction of blood pressures. And that was with first measurement of blood pressure. So apples to apples, right? A good comparison there over time. So again, that was sort of step one, and again, published in 2019. And then we were able to ask some additional questions and say, okay, what else would we like to know? So it worked in one system in an academic setting. It worked when I was in the clinic. So again, maybe some questions here about that. And what else could we learn? And so some of the other things we wanted to know were, what about the people here at UW who were told to go back and follow up who didn't have in-network primary care? What if you had a primary care doc at group health was one of our questions. Second question was, what if you wanted to try to do this in, say, Milwaukee in a rheumatology clinic? And our third question was, what if you wanted to look at this in a non-rheumatology clinic? How would things go? So to answer that first question, we actually partnered with folks at Group Health, and I'll actually point out here, and this is maybe a good segue too, is Jenny Abraham, who's on the left here, actually had approached me after a state symposium on hypertension, and she had said, "Hey, I'm from Group Health, and I really want to do BP Connect at our site." And I said, the funny thing is, we've been trying to get our patients, your patients to go back too. Let's look at the data and see what happened. Okay, so Jenny was she was in the quality department at Group Health and was on board right away. She talked to her supervisor, and they have been fabulous partners with us. So just a quick little plug that it's great to do these state health collaboratories, because you actually meet partners that can help us answer interesting questions. So essentially what we said is, let's go back through the couple years of data that we then had. Let's transfer those EPIC ID numbers and the encounter dates of when we told them they should go get follow-up, and let's see what happened on the other side of the firewall at Group Health. Did they actually come in and get primary care follow-up? So we transferred, first of all, EPIC numbers from UW to Group Health. And then once we got the data out of Group Health, we had them send us back just a limited data set. They basically then put on a pseudo ID, dropped the direct identifier, and sent it back to us here at UW Health. So again, a little bit of gymnastics to keep this all HIPAA compliant, but the beautiful thing is they were their patients anyway. So we sent them their own numbers, they ran it, got us data, and then sent it back that we could marry on to the rows of data we already had. And essentially then we didn't have any access to those direct identifiers. So again, it was limited data and able to be secure transferred. So we were able to then ask the question, what happens with a cross network follow-up versus within system? And so what we saw here was, compared to our previous publication in the blue on the bottom here, where we saw an odds ratio, actually this is just showing that early odds ratio, which was around 2. What we saw was at Group Health, telling people to follow up and not scheduling it was not enough. That actually this confidence interval crosses 1. The person featured here is Dr. Sancha Ferguson, who's my medical director in our department, who helped write up this study. And so interestingly here, then our phase 2 with Group Health was to say, Group Health, could we have a hotline so we can directly schedule with you? Because we see that just telling people to follow up doesn't do it. Let's get a hotline. And so we are in the process now of testing that hotline method with Group Health, because we did this controlled analysis. So maybe we help patients with situational awareness, but we didn't help them actually get in within that 4 weeks. And so we're going to try to do phase 2, which is direct scheduling with GHC as well. So that is ongoing. All right. So direct scheduling seemed to matter on that one. All right. Now, the next piece was working with Medical College of Wisconsin, as I mentioned to you. So MCW Rheumatology had seen our results and was totally on board. And then the other place where they were on board was, I had a couple of colleagues in GYN who were also D&I researchers, Dr. McCabe Williams and Dr. Heidi Brown. And so first, we decided that we should just replicate the study in GYN here at UW Health, and we did that. You can see here that the reporting structure that we had created for UW Rheumatology basically was then scalable across other clinics. So this is just using those same reports. And you can see that on the left-hand column here, that logic that we created was really spelled out on how to get the numerator and denominator for each of these care steps to do that monthly reporting. I'll tell you that the effort we put into this up front was incredibly helpful, because then when we went to new sites or added new clinics, we could just basically scale up and kind of create the same monthly aggregated performance reports. The second thing is, at Medical College of Wisconsin, we wanted to, again, be able to get some patient level control factors. And so we worked with an analyst in their CTSA to say, one time at the end of this, could you help us pull a pre-post comparison at MCW that, again, we could cluster by patient, and then we'd have some sociodemographics and some flags for the primary care status if patients had primary care and then in network. So again, you can see how we sort of the logic behind building the data structure was able to be transferred to new sites. But one of the downsides of the pragmatic study approach is actually just that life is also happening at these sites while you are getting grant funding. So the life that was happening at Medical College of Wisconsin was that they were implementing, between the 9 months that we put in our grant in and got funded, they actually did a homebrew version of trying to do a hypertension intervention. And so again, we decided we would make some lemonade, and we ended up doing a little bit of a comparison, a comparative effectiveness, and I'll tell you a little bit more about that. But essentially what happened was our protocol did direct engagement with staff. Their institutional protocol, they basically just said that there was an EHR alert, and it was telling them to send people back to primary care, but there was the referral was typically asynchronous. Someone would call after the fact to try to get a visit. So in contrast to us, where we did that engagement step, we educated the staff, we had an EMR alert, and we did that audit feedback, and then we real-time scheduled we had a 6-month period before our intervention where all they had was just an alert and asynchronous scheduling. So we use that to basically, again, compare and contrast the two approaches, again, using EMR data. And the first thing that we saw was that comparing their initial, again, first 2 months of the BP Connect intervention versus the first 2 months of their homebrew intervention. And again, looking at outcomes here, we could see that we had 46% of patients saying yes to follow-up versus they had only 8% in that asynchronous. So again, you can see that that synchronous scheduling really does seem to matter. You catch people right at the moment that they have a high blood pressure, and they're a lot more likely to come back in. And then we were able to show over time that we were also able to, again, show that even in adjusted analyses that BP Connect increased the likelihood of follow-up. And I'll actually point out here too, this was during the pandemic. So this was at a time where people were actually utilizing health services less, and we were still able to show a statistically significant increase in timely follow-up. And again, it worked overall, and it worked specifically within patients of Black race who are at particularly high risk for hypertension outcomes and cardiovascular disease. So this was, again, nice to see. And this is a poster with a learner that'll be presented this year at the ACR meeting. In this GYN subspecialty group, again, looking kind of using that same pre-post study, we were able to show, again, we doubled timely follow-up. And so we're proud of that. And that has been published with Heidi Williams and Makeba Williams and Heidi Brown in the American Journal of Obstetrics and Gynecology. And proud to have demonstrated that. And really then we've answered a number of questions in the hypertension space. We're continuing to follow this up to see kind of long-term outcomes for patients and to see what else happens over time. We're also learning things about refreshing. So one of the things that we've seen is that staff, during the pandemic, rooming got expedited, or we had some staff shortages. So we are now doing some refreshers in each of these clinics, trying to do that on about an annual basis because we realize there is some turnover of medical assistant staff. But again, those talking points and some of the other things that we've built in here have helped us to sustain over time. And this intervention is live at Medical College of Wisconsin, at Gunderson, at UW, and then in one of the GYN clinics as well. So again, or a couple of the GYN clinics as well. So again, that's where we landed on the BP Connect project. The second kind of related pragmatic study that we did was this Quick Connect project. And again, some of you have heard me talk about this before, but the idea is just that there's free quit lines in every state. And we know that people who continue to smoke, for instance, have worse outcomes with rheumatoid arthritis and lupus. And one of the interesting things with rheumatoid arthritis is their medicines, for instance, cost about $2,500 a month, and the medicines work less well if you continue to smoke. So when we tell patients this, they're kind of shocked and actually grateful when we let them know that if they can quit smoking, their medicines might work better and they might have better outcomes. A lot of them hadn't heard that message when we kind of did some early focus groups with them. So we've tried to adapt from primary care ways that, again, we can do some at point of care interventions. That BP Connect intervention that I kind of talked you through briefly takes about 3 minutes at point of care. This is a beautiful intervention that takes about 10 seconds to screen and takes 90 seconds to complete the entire intervention. So 90 seconds from start to finish. And the idea is that if you ask patients who are currently smokers, if they thought about cutting back or quitting in the next 30 days, it turns out that about a third of them have thought about cutting back or quitting in the next 30 days, in which case you can offer to connect them to a quit line, which, like I said, is a free resource in 50 states. And several of the states, including the states we've implemented in Wisconsin and Georgia, will mail the patients free nicotine replacement therapy. So super cool that we can actually really briefly screen and intervene using free statewide resources. So Quick Connect was our intervention looking at whether we could use that same framework of check, cueing about readiness to quit, advising why it matters in rheumatic disease, and connecting people to the quit line. Again, doing that in a 90-second interaction. Same components of implementation with engage, educate, remind, and feedback. And our question was really, one, could we improve quit line referrals and cessation versus usual care? And again, broad pragmatic inclusion. Anybody who was in our clinic that smoked reported that they were smokers. And then for the outcome of accepting referral, it was basically just those who were ready to quit. So again, big population level questions. And again, grateful to Edmund Ramley, who helped us design that intervention with our teams. Again, Danny Pandyard from who had previously worked at EPIC helped us build the intervention toolkit. And so he, again, helped us nest those talking points in here. And then the order was tagged with that smart data element so we could count how many times people took that order to the quit line. So again, you could click the box and it would send through something that's called an HL7 interface. It would send to the quit line. And the vendor that actually serves half of the states in America is Optum, part of United Health. Some of you may have heard the speaker from Optum yesterday for the IT grand rounds, who is really fantastic. But at any rate, we could send the information to them to have them reach out to the patient. And then when Optum reached the patient, they would send EMR data right back to us. And actually, we'd have on the green circle here, we'd see the date that they contacted the patient, whether the patient took meds, and if the patient set a quit date. And all of that gets resulted right back to the EMR. So one, we were able to build it. Two, we were able to create the manual so that other people could build this. And three, we were able to sort of benchmark the data reporting using this approach. So again, similarly, we created sort of two data sets. One was the staff performance, kind of those process measures that we reported monthly from the EMR and gave audit feedback on. And the other was we did this pre-post comparison with patient visit level data that were limited data. And in addition to kind of the data set that we talked about before for BP Connect, we also added those quit line reports where we had whether they accepted coaching, medications, or if they set a quit date. Okay, so we had some additional data points and data sources on this one. Again, we 26-fold increased the rate of quit line referrals, so that was fantastic. And again, to date, have more than 200 referrals to the quit line. So that was a win. We also were able to partner with some folks at C-Tree. Again, initially, when we started building this back in like the 2015 era, we worked with them to talk about how to use the EMR tools to set this up and use best practices. And Megan Piper has been a fabulous partner to me on several of these studies. But the other thing we did is we actually had C-Tree call patients to say, if you tried to quit, did you stay quit? Did it work? Sort of thing. So we had what we found in the Pragmatic study was that 421 patients had indicated they were ready to quit, or excuse me, were asked about ready to quit, excuse me. And then 122 of them said, yes, I was ready to quit. 93 of them got a referral offer. And amongst those who were offered, 71% of them accepted that referral. So again, we use that as sort of that behavioral question. So this was not a contentious ask. It was just like, hey, have you thought about quitting? And if people said yes, we offered to get them the resources they needed for that. And the beautiful thing there was that among those folks, 1 in 4 actually reported a quit attempt. So there were 16 quit attempts. And then we had them follow up. And actually over time, it was even higher than 16. This, I think, was our 6-month data. This was 1 year follow-up. So at 1 year, here there's about 33% of people stayed quit for 6 months. And 94% of them said they were super satisfied with this intervention. So again, able to use different data sources and different ways to kind of look at our analysis. Now, I mentioned to you earlier that we built this BP, we built this Quick Connect at UW, and then we wanted to think about, how would we do this elsewhere? One of the other lessons learned that I'm actually going to pitch to this group is that when we went to UW, we actually needed to work with, here you can see 15 or 16 different groups to get this all built. At Gunderson, we ran this checklist with them that we had created, and it actually was about 4 people that we needed permissions from that could build this whole thing, because Gunderson's just a smaller organization, and the big ship has more committees and more silos. And so what we ended up with this one was we had a publication talking a little bit about stakeholders, but we call this our stakeholder checklist. So again, I would encourage all of you, when you're thinking about bringing something from one institution to the other, also lessons learned about different stakeholders that might need input. When we created this checklist, the great thing was we could just bring this right to Gunderson, and then they could say, oh, these 4 names will get you all of these things checked off. Versus, again, at other large academic centers, when we bring this, it might be 11 different names for those 16 committees, but we have it sort of mapped out. This is actually, again, that we published this with Edmund Ramley, Danny Panyard, who I mentioned before, but also Shannon Dean, who's now the CMIO for St. Jude's Children's Hospital, but was previously here at UW. And so again, helping us to take the mental model of an IT department and take the mental model of a health system who might need to sort of execute the plan that you have in mind. So this is a nice checklist if anybody wants to use it. So that when you're doing recruitment science, you're also recruiting the teams that do all of these functionalities that you might be impacting. So anyway, so the cool thing was the Gunderson was actually a fun thing. They were able to build BP Connect in a day. They could build the reporting, and they built Quit Connect in a week. And so they were able to show us that our cookbooks and our build guide actually worked. And they were able to demonstrate that they could, again, increase their referral, smoking cessation referrals. And then they also implemented the BP Connect and had good results on that as well. So again, able to demonstrate that in a community setting, we could replicate the results we had previously. And then specifically here on Quick Connect, we wanted to really stress test the intervention. So we partnered with folks at Emory Grady in Atlanta. So it's a safety net hospital in downtown Atlanta. And their sociodemographics were that they had a patient population that was 78% Black. They were over 50% public insurance, about a third were self-pay and uninsured, and then about 12% Hispanic race ethnicity. So Dr. Lim on the left here is one of the world's leading lupus experts, and Dr. Brandt on the right was our physician champion for the project. And again, we said, if we can implement it at Grady and they can do it there, probably people could do it almost anywhere because this is a pretty low resource setting. So we partnered, and Dr. Brandt partnered with the medical assistants and again, taught them how to check, advise, and connect patients back. We built in the EMR, and we'll talk to you a little bit about the lessons learned there, but we were able to again demonstrate that Ready to Quit was not being asked at baseline, but again, doing this through the pandemic, we were able to get people onboarded, and we had 104 people who were referred to the Quit line during that time period. Again, this is an example of where simultaneously other things are happening in the health system. They had created a class pre-pandemic, and so we also monitored the number of people who could get referred to that class because they wanted to not have competing interventions. And so we basically just made the offer for either clinic or class. And as you might imagine, during COVID, they couldn't do the class. And so it was almost all folks ending up going to the Quit line. But again, we offered both, and we were able to then do a little bit of comparative effectiveness during the different periods where they had the option of doing both. So again, serendipity sometimes also gets you sort of natural experiments as well to ask some other questions. Beautiful thing was that nationwide, what we knew was that during COVID, cigarette sales actually went up. But in this population, we showed that we had higher rates of referrals to Quit line and higher uptake of setting quit dates. So we had countercultural results showing that something different was happening in this setting, which was really great. So what we saw was that we were able to reach a number of people and that we had a quit date set in progress for 37% of the folks that we reached out to. So again, and we're able to connect with. So again, low tech intervention, low cost, and potentially some high yield in return. And even when we did adjusted analyses on this pre and post of 500 patients who smoked, what we saw was that we were 20-fold more likely to get them to have a quit intervention offer. And then what we saw here was an interesting and somewhat surprising effect that here we made the Black race group referent because almost 80% of their population was of the Black racial group. It also was interesting that 100% of their staff in their clinic for their medical assistants and nurses were of Black race. And what we found was actually it was more effective in patients of Black race than it was of patients of white race, which was interesting here. And this might again tell us there have been other studies that have said that maybe racial concordance of staff actually might impact outcomes. So this might be a place where this might matter. The other reason this might matter in smoking that we've thought about is that, again, if doctors are pitching smoking cessation, very few doctors have previously been smokers. And yet when medical assistants are pitching this, many, when we've done our studies, a third to even 40% of our medical assistants who often come from lower socioeconomic backgrounds and less education, many of them have already quit. So we can actually leverage their real world experience by having them be the person who delivers this ask and offer in a really sincere and kind of level playing ground. So interesting finding here. We're going to learn more about that, but that was sort of an unexpected finding that we want to learn more about over time, but kind of cool that at Grady, and then we could really celebrate those MAs and nurses who really helped us to create this great outcome. This is still in effect at Grady, and they're looking at potentially bringing it to other clinics there in their health system. So when we kind of sort of circled back, the other thing we wanted to, Grady was a success story in that we got to the end point and we were able to deliver tobacco cessation intervention and referrals to their patients. But it also taught us some things about, for instance, that this build for Quick Connect with that HL7 interface is a harder build. You can just imagine just technically that's harder. So we actually convened a focus group of the people who helped us build the intervention and the people who helped us build the reporting so that we could learn a little bit about our process there. And so people were really excited. They said, it was great that a lot of that was in the build guide. It was great that we had some co-building. We had some sessions occasionally when we could have troubleshooting. We'd actually look at their code and double check it against what we had in our code book. The HL7 specifications were fairly straightforward, but one of the things we found was that they weren't getting their HL7 results to land because we set it all up, but there were some delays and they actually didn't turn the thing on for reporting. And it was a couple of months into reporting where we were seeing 0, 0, 0 that we said, oh, wait a minute, go back and turn that thing on so that the result lands in the EMR. And we had to have them resend it from the quit line. So kind of comical things happen sometimes. So again, what she said here too is upfront, if we had sort of done more back and forth testing, it might have helped. But again, this just tells you a little bit that the analogy yesterday that the Optum speaker used was basically saying that, sometimes when you're doing research along with real world implementation, the train is going and you just have to kind of catch up. And so here the train was going. By the time we got the build going and the reporting going, they were two separate teams, and it took a second for them to realize that one piece of this hadn't gotten switched on. So again, check, recheck, and recheck your recheck, I guess, is the answer there. But again, some good lessons learned and some helpful feedback from the implementation team that included those reporters and builders. The cool thing was this BP or this Quick Connect intervention. Again, if we think about this, 10-second asking about readiness to quit, 80-second referral, was that this is incredibly cost effective. This is an old figure. Medical assistants thankfully make a little bit more than this, but just back of the envelope, again, it was about $15 per quit at UW Health. It was about $4 per quit at Grady. So again, incredibly cost effective to do this. And again, we were able to make the sales pitch to continue this in our clinics. So now we've actually done the BP and Quick Connect in a number of different Wisconsin clinics. Now we've done the Grady Quick Connect intervention. And you can see here on the right that, these represent really vastly different socio-demographic groups, with the red being people of area deprivation index using Dr. Kine's ADI index, that again, the Milwaukee Center core, and actually also the heart of Atlanta. Grady is right in the heart of the red zone of Atlanta. And again, high smoking rates in both of those states compared to sort of national averages. So we would love to think about scaling these up and doing these a larger study in more centers. And that's kind of where we're looking next, is to do a larger cluster randomized study. And we had pitched that once before, but we'll be pitching that again soon. So stay tuned on that. We've got Connect Health resources, or where those toolkits live. We've had 1,100 downloads of the BP Connect tool, so that's kind of a cool fact. And it's been disseminated by the Million Hearts and the American CDC and American Heart Association, because we meet best practices for systematic measurement and connection after systems level action on blood pressure, which has been pretty cool. And we've learned a lot of lessons along the way. So we've learned, first of all, that we can improve outcomes overall and specifically reduce disparities when we use these protocol-based care. The second thing we learned was that it's really important to engage staff, but expect turnover, right? That's sort of the name of the game. I don't know if many of you probably have had some of these experiences as well, but certainly frontline staff can have some turnover. And so things like embedding talking points and refreshers and retraining can be important. Likewise, having champions in the clinic so that keep going, and having good relationships with those clinic managers can really make a difference. The next bullet I put here was just teams vary, and I would just really point out that not all IT teams or research teams have the same capabilities. So sometimes it was helpful for us to just do that elbow to elbow build or troubleshooting, because occasionally we'd see that there was something like the thing wasn't turned on, right? Like, and we after, it helped to kind of get under the hood with them and say, oh, here we go. And they appreciated the coaching help. But that interface build, for instance, was a trickier one. So we had to do a little more support on that piece. And then finally, one of the things that we're doing now with the BP and Quick Connect here at UW is we're really trying to embed the reporting within operations. At some of our other sites, we'd already done that, and it makes it easy because then it just comes operationally monthly or every quarter or whatever we ask for. But certainly when the research dollars are up, it also is important if you want to continue your intervention to think a little bit about that sustainability reporting. And so again, we've pivoted and we're working on that at this point too. So hopefully you've gotten a little flavor for what pragmatic studies might have to offer, how you can do some data and do some adjusted analyses to overcome the limitations of pragmatic studies, how you can get builds and reporting done at multi-center studies, and a little bit about how to work with teams effectively. And I just want to say thank you to, first of all, on the left, upper left is Monica Messina, who's my fabulous lab manager. Also, Andrea Gilmore is on the second row, Sancha Ferguson. Andrea has been one of the people who also has done a lot of qualitative work with us over the years. Many people on this slide that I'm incredibly grateful to, and I won't list everybody on the slide, but again, thanks to the many collaborators and funders we've had over the years. And I'm excited. We're doing some additional work in the lupus and the lupus equity space that I didn't hit on today, but that's kind of our next frontier, and we're really excited about that and excited to continue to disseminate this work. And with that, I will pause and take some questions.
Thank you, Dr. Bartels. This was great. The challenges of pragmatic trials, there are those. And then there's just all the exciting findings and opportunities and lessons learned, and for us to figure out how do we move this line of research so that we close that 17-year gap from clinical trials to can we really be effective in real world. So it's fun to see your results here and to see the spread and the uptake by so many other healthcare organizations. It's really pretty phenomenal. So I'm going to open this up to, we've got a few minutes here. We want to be able to provide an opportunity for questions that people would like to ask Dr. Bartels. So you can unmute and ask your question or raise your hand, and we'll also monitor the chat as another option.
Barb, while we're waiting for questions, I'm going to also give a quick shout out to Kat Phillips, because we certainly worked with the folks in the cards group along the way. And also Alice Uroff helped us do some focus groups years ago. I see her on the call here too, when we did the Gunderson implementation. So again, it takes a team, and deeply grateful.
Looks like Farah, you have a question, and then go ahead.
Hi, Christy. You're amazing. I've always known that, but this is so great to hear about all the amazing things you're doing. How do you keep all these balls in the air at the same time? I know it's kind of a process question, but for those of us who are just starting to think about this, I can barely think about doing one aim, much less all these things at the same time.
So Farah, you've got superpowers too, and I know this about you, but the other piece is, Monica's been a fabulous partner. And then I do think having site champions at each site, at Medical College of Wisconsin, we had, again, site champions there. We had site champions. So I think the other piece is you just find somebody who's super motivated. And then I will also maybe point out too, actually, both at Medical College and at Emory, we had a senior person who had a biosketch and knew how to do research, and then we mentored a junior person. So we mentored Dave Gaisley, who actually has come up through the ranks and had a number of publications with us and is working with other people. And then that Jennifer Brandt I mentioned. The other piece is, so you can sometimes structure these too, where you can sort of partner with a junior and a senior person. The junior person will help you do the lifting at that site, and the senior person can help get it done or make sure that you've got, the right RBs and the right contracting and all of those other pieces too. So I think that might be one other lesson, is basically partnering with other institutions and not being afraid to mentor as you go. Pierre, is that helpful?
Yeah, I definitely kind of along the lines of the question that Molly asked in follow-up, just where did you make those connections? How did you meet those people at Grady? I mean, MCW obviously, but
Yeah, no, I think that's great. So, Medical College of Wisconsin, I knew their chair, Dr. Rosenthal. And so Anne was a bench scientist and she was like, sure, like you can put me on the grant. Like, I don't know anything about doing health services research, but yeah, put me on. So when we first started doing collaborations, and then basically when Anne started having narrower bandwidth, she said, would you mentor my junior guy? And I was like, sure, absolutely. So that kind of grew organically. The Grady partnership was sort of twofold. One is I actually recruited a junior faculty from there. And two was I was on national committees with Sam, and I knew he had one of the 5 CDC centers of excellence. And so I just at a meeting told him what I was doing. He was like, that's really cool. We never have any QI, like we basically don't have any bandwidth for anyone to do that here. And I said, could I, if I came, could I? And again, he said, I don't exactly have bandwidth for this, but I've got a junior faculty who I can pair with you. And sure, this would be great. So I'd say just don't be afraid to make those connections and reach out. But again, in Grady, we've had good success. So let us know if we can help connect you too. But those are a couple of good examples.
thank you.
You bet. And Molly, thank you for the question here too. Yeah, what prompted the Grady inclusion? So yeah, I knew Sam had this. One of the other things actually, Molly, that you'll maybe laugh here too, is that Sam and I have done some cardiovascular disease research, and Sam sort of jokes, but he basically needs more white people with lupus, which makes Wisconsin a fabulous partner. So we have been doing some lupus research with them at Grady over the years, where we can kind of pool data from their center and our center. But again, just someone who is deeply committed to the mission of helping to reduce disparities and reduce cardiovascular disease, and asking it in interesting ways, and someone who's open to systematic change. But really, I do think that mentoring those junior faculty was a fun thing. Monica, you're on too. Do you want to say anything else about the connection piece of this or the scale up piece of this? You've been key to this too.
I think that was great what you said, because partnering with the physicians who had more bandwidth really was effective for us, and they were very passionate about seeing this improvement, but they could actually have the boots on the ground. So I think that was key. Well, and also Christie, not to, but your understanding of the lift is also really important, because it made it more real for everybody.
Shafika, I noticed that you had your hands up earlier. Oh, there we go, into the chat. Thank you so much.
Okay, so Shavika says, I work in CVD prevention in LMIC, and I was wondering if you could share a bit more about your experience working with medical assistants at Grady. We always assumed task shifting to lay health workers are feasible in our settings, but training is often lacking. I will tell you one of the things. So Shavika, I hope you can maybe pop on and say your own comments here too. But I would say specialty clinic medical assistants are less burned out by like the EMR alerts. That primary care, they get a lot of those, and they get engaged all the time in quality improvement initiatives or things like this. When we've done interventions for implementation science interventions in most of these settings, a lot of these folks have never been engaged for improvement initiatives in specialty clinics, or they've been engaged for very few. So I'll tell you a couple things. One is that actually those focus groups we do at the beginning, we give everybody, $50 to $100. We invite them to the table and we get them food. And the goodwill that alone builds is unbelievable, but it helps. And we then tell them, tell us why this would or wouldn't work in your clinic, or help us break it so we could fix it and make it doable in your setting. So I think Monica was kind of alluding to that. Like, I get how fast paced these clinics are, and we get how hard it all can be, but we ask them and we tell them, you are our expert partners here. So they help us build it. And that co-creation, I think, helps them have ownership to then keep the thing going. Shafika, is there anything else in your question there that that might be helpful?
Yeah, thank you so much. I'm not sure I stated it well enough, but basically we're working in resource settings that aren't even as well organized or have specialty clinics. And most of the times we're even just trying to shift things to community-based settings. And what I've always found frustrating is we say, oh, great, task shifting has been shown to work in other small trials, but nobody actually evaluates the training of that. So I was just wondering what kind of formal training your medical assistants had. And just to allude to your last point, we do try to do pre-formative evaluations where we get feedback from the low resources, levels of resources of staff that we already have to understand how burdened they already are and what they think is lacking and how we can accommodate them. I'm just always left a little frustrated by the fact that we can't, if we train somebody to do this task and they do it well, it's rare that we understand why that aspect is working. So I was just curious if you had similar challenges with medical assistants working in your low resource clinics. So, but thank you. What you said was very helpful.
And the training, I will say too, the training that we did do upfront, for instance, for BP Connect, we actually had a state health educator come and do on-site training here in Wisconsin, and then we did it remotely, but basically just showing them, again, refresher on technique and reminding them how to do a good blood pressure reading, and then explaining to them why it mattered. I do think that also giving them their individual audit feedback, many of them felt really engaged because I think it elevated their personal perception of their own professionalism. They're like, oh, I did that. I referred 4 patients last month, or I, got 20 people back to primary care. So I think sharing the wins with them as individuals was also another part of that was really well received. Often our MAs told us, we've been part of projects before. No one ever tells us what happens afterwards or what a difference each of us made. So I think that's another piece. And the clinic manager can help you find MA champions. So I'd imagine that probably would also work with your lay workers. I don't know if they're motivated by seeing their own performance or hearing.
Yeah. Well, I can confirm that currently in a study in South Africa that we're doing in a rural setting where the uncontrolled hypertension is upwards of 55%, we have definitely been doing some clinic level audit feedback, and that is very empowering for our lay health workers. So
I love that.
Thank you very much.
No,
great
thank
presentation.
I look forward to visiting more with you. That sounds like a fascinating project. And then Harold Climbs says he likes the stakeholder creep term, and isn't that funny? It is a pretty good paper, but basically it does it gets hard. And so basically, we made the joke in the paper that rather than scope creep, this was stakeholder creep, that you'd go to one committee and they'd say, oh, this is fine, but you need to go to these 3 other committees and then 3 more committees, and there's actually a runs chart that you can see all the different committees we ended up going to. And we've given some feedback to UW Health again that we maybe could make this easier to do the right thing. But the other piece is just make a map and share your map with other people. Once you figure out how to navigate the system, share it and don't make it any harder than it has to be, I guess is the other piece there. So great.
Well, Christie, even my dog is coming here and saying what a great presentation this was. So thank you for kicking us off for our seminar series this academic year. Again, there's a link for our evaluation. Please give us your feedback. It always helps us make things better. In case you don't give us feedback here, you'll get an email from us with another link to feedback. Also, to let you know where our YouTube channel is, because all these presentations. Thank you for doing the shout out for the short course. We're really excited about the short course in person. It's free. So please spread the word about this wonderful opportunity for collegial learning that we'll all have together. So again, I want to thank Dr. Bartels for providing this really impressive and wonderful presentation. So we will see you next time, October 11th. Next presentation.
Thank you.